Module 6, Classification of Alveolar Bone Defects and Treatment Plan. In this module, a classification of alveolar bone defects will be presented to guide the proper planning to manage compromised socket regardless of the severity of the bone loss. In 2007, this team developed a socket classification. They classify the sockets in type 1, 2, and 3. Type 1, when we have the absence of soft tissue defect, the presence of the buccal bone wall, so we have an intact socket. In this case, they recommend to do immediate implantation and immediate provisionalization and the bone filling to fill completely the gaps at the facial aspect. Type 2 socket, the absence of soft tissue defect, and we have the presence of partial or total loss of the buccal bone wall. They recommend to do late or early implantation using bone graft to restore the defect, GBR procedures in combination with membranes. In type 3, when we have the presence of soft tissue defects in combination with total loss of buccal bone wall. In type 3 socket, according to them, it's recommended to do a late implantation plus bone graft GBR procedure in combination with membranes. In 2015, a subclassification of extraction sockets with buccal bone defect was proposed by these authors. The main focus was type 2 socket. They classified the type 2 in 2A, 2B, and 2C socket. 2A, when the extent of the bone defects was between 5 to 6 millimeters in height. 2B, the bone defects between 7 to 9 millimeters at the buccal aspect, and 2C, 10 millimeters or greater than that. They recommend to do the tooth extraction plus implant plus GBR using biomaterial plus CT graft, connective tissue graft, using either flap or flapless procedures. This is the main difference between this kind of treatment with IDR procedure. In IDR technique, everything is going to be solved in one single procedure without open the flap, in combination with immediate provisionalization and bone reconstruction at the same time. Since 2006, we developed a classification of alveolar bone defects. It was written in one of the chapters of our book, Immediate Dental Velar Restoration book. And what's the main difference between this classification and the one that I showed before? This classification is based on the bone defects, and the measurement of the bone defects depends on the proportion between the extension of the bone loss and the root length. And we have to know if the bone defect extends to the cervical third, middle third, or apical third of the root. In order to facilitate the treatment planning, we developed this new bone defect classification. So since 2006, we've been working with this classification. And the bone defects were classified from R1 to R6. R1, when we have the buccal bone loss at the cervical third of the root. R2, the buccal bone loss at the middle third of the root. R3, the buccal bone loss at the apical third of the root. R4, when we have total loss of the buccal bone wall in combination with gingival recession. R5, when we have bone loss in the proximal wall, either in the mesial or distal aspect. And R6, the bone loss at the palatal aspect. Take a look at this illustration to keep in mind these 6 types of defect. Type 1, when the defect is placed in the cervical third of the root. In this slide, you can see the R1 defect through this illustration or dry skull. Type 2, when the defects are placed at the middle third of the root. Through this dry skull, you can see here the defect type R2. Just to keep in mind that this bone defect classification is related to the root length. So in case like this, if we have, for example, 11 millimeters in length of the root, if we have the bone loss extending 6 millimeters length, we can consider a type 2, R2 defect. Here, R3 defect, the bone loss at the apical third of the root. You can see through this dry skull that the patient lost completely the buccal wall until the apex of the root. R4, when we have the combination between the gingival recession, the total loss of the buccal bone wall extending beyond the root limits in the coronal apical direction and the mesial distal aspect. R5, when we have the bone loss in the proximal wall, either in the mesial or distal aspect, as you can see in this dry skull. And here R6 defect, that is placed in the palatal wall. If we have defect at the palatal aspect, regardless of the extension, the length of the defect we consider type R6. Let's sum up this classification of alveolar bone defects. R1, when the defect is placed at the cervical third of the root. R2, at the middle third of the root. R3, at the apical third of the root. R4, when we have the defect extending beyond the root limits, the total loss of the buccal bone wall extending beyond the root limits, in combination with gingival recession. R5, when we have the bone loss at the proximal aspect, either in the mesial or the distal bone ridge. And R6, bone loss at the palatal wall. You can see the dry skull. You can clearly see the main difference between R1 to R4. R1 at the cervical third, R2 at the middle third of the root, R3 at the apical third of the root, and R4, total loss of the bone wall extending beyond the root limits in the coronal apical direction and the mesial distal aspect. Let's focus on the treatment planning, regardless of the extension of the bone defect, from R1 to R6. In case that we have defects type R1, 2, 3, and 6, the main recommendation is corticocancellous block graft to restore the defect. When we have defects type R5 in the proximal wall, it's mandatory to use cancellous graft to restore the bone ridge. When we have defects type R4, it's mandatory to use a triple graft because we have to restore hard and soft tissue damage. Here you can see two clinical images plus the CBCT scan. And what's missing here? Of course, you know that is missing the buccal bone wall. We have already discussed about this. If you only extract the tooth, we would have the tissue shrinkage towards to the center of the defect. But the question is, which bone graft material do you prefer? Here you can see two different options. You can use biomaterial or autogenous bone graft. Autogenous that can come from retromolar area or from tuberosity. And we have main difference between these three kinds of graft. Of course, the main difference is about the color, but not only that. Talk about clinical applications. Biomaterial is mostly used for filling the gaps in intact socket. In compromised sockets, according to the literature, it's recommended to do guided bone regeneration in combination with membranes. So we have to open a flap in order to restore the defect. Bone graft harvest from retromolar area. It's mandatory to open a flap because we have to stabilize the graft by screws. But bone graft harvest from the tuberosity, we don't need to open a flap. This is a blinded surgery. We never open the flap in order to restore the defects. And take a look at the graft vascularization. In biomaterial, we cannot find any viable cells. Bone graft from retromolar area, a low number of viable cells. It's because it's more cortical. But bone graft harvest from tuberosity, we will find a high number of viable cells. It's very well vascularized graft. And according to the literature, biomaterial, when we use biomaterial, we can wait between 7 and 8 months before we go to the next step. That can be implant installation or implants uncovering. Bone graft from retromolar area, we should wait between 5 and 6 months. Bone graft from the tuberosity, we only wait between 3 and 4 months before we go to the next step. What's next? To take the impression and to make the final restoration. So when we use either biomaterial or bone from retromolar area, everything is going to be solved in 2 or 3 steps, 2 or 3 surgeries. When we apply the IDR technique using tuberosity bone graft, everything is going to be solved in one single step, one single procedure. What's the importance of using a graft as a natural scaffold filled of osteoblastic cells and growth factors? Take a look at this case. This patient here lost completely the buccal wall. Our goal here is to replace the buccal wall that the patient had lost. This is why we use bone from the tuberosity as a new buccal bone wall. We can use this piece of bone as a biological membrane. Our main goal is to have a result, an outcome like this. A bulky soft tissue along the months and along the years. This is our target. In every single tooth to be replaced, regardless of the area to be replaced. Up or down, anterior or posterior, doesn't matter. We are always looking for a bulky soft tissue, especially at the facial aspect of the implant. This is the CBCT scan that was taken after 4 months. You can only see here vital bone tissue, completely remodeled and incorporated. And pay attention also that the bone graft that we have placed over the implant platform still remain over the implant platform. That's amazing. This is what we were looking for many years. So we always fill the gap or reconstruct the wall with autogenous bone graft harvest from the maxillary tuberosity, regardless of the size of the gap and extent of the bone defects. Here we replace right central incisors in different patients using the same methodology, but pay attention to the final outcomes. We have the maintenance of the anatomical contour of soft tissue. So we got the soft tissue stability and the soft tissue maintenance. Here, another example of using autogenous from tuberosity. Here we have a periodontally compromised patient, many teeth to be extracted. We extract this teeth, apply minimally invasive procedures. We apply the IDR technique. We restore all the sockets one by one using bone from the tuberosity. And in the dentular site, we apply flapless procedure. And we install the implants and we made the provisional restoration immediately. 3 fixed prostheses in anterior zone, in the posterior zone, in the right and the left side. And pay attention here, after 3 months, we remove the provisional restoration in order to evaluate the soft tissue quality and maintenance. So, you can see here the periodontal biotype conversion. We start with a thin periodontal biotype. And 3 months later, we had extremely thick periodontal biotype. We changed completely the scenario, as you can see prior and 3 months later. You can see here the maintenance, not only the anatomical contour of soft tissue, the gingival margin, but also the papillary height position. And I want to call your attention to the maintenance of volume of soft tissue, especially at the facial aspect, because the soft tissue is being maintained in the same position due to the presence of the bone graft. In this module, you've seen not only the alveolar bone defect classification, but also the correct treatment planning related to each type of bone defect. We also emphasized the importance of using autogenous graft to allow for a better biological tissue response.